A systematic review published in Nutrients examining the effects of creatine supplementation on brain function found consistent improvements in tasks requiring short-term memory, intelligence, and reasoning performance across randomized controlled trials in older adults at doses of 3 to 5 grams per day of creatine monohydrate. The same compound that has been studied in gym settings for decades turns out to have a different and largely unrecognized application in the 55-plus population, supporting the cognitive and physical systems that decline most markedly with age. Creatine is arguably the most studied non-prescription supplement in the world. The evidence for what it does to the aging brain and aging muscle is not gym floor knowledge, it is peer-reviewed science, and it deserves a careful look. There is a cultural bias embedded in how most people over 55 think about creatine. It has been sold, marketed, and publicly associated with young male bodybuilders seeking rapid muscle mass gains. For many adults in the 55-plus demographic, the word creatine triggers an association with protein powder dispensaries and athletic performance optimization, not with cognitive health maintenance, not with age-related muscle loss prevention, and certainly not with something a 60-year-old retired professional would seriously consider. That cultural framing is a disservice to the evidence. The compound itself is an amino acid derivative that the human body produces endogenously, obtains from dietary animal foods, and distributes throughout metabolically active tissues, including the brain. Its role in energy metabolism is fundamental, conserved across species, and relevant at every age. What changes with aging is that the system it supports becomes more dependent on supplemental support. In this video, we will cover what creatine actually does in the body and brain at the biochemical level, why it becomes particularly relevant to aging tissue as we move through our 50s and 60s, what the Forbes systematic review found about cognitive and physical outcomes in older adults, why sleep deprivation and cognitive fatigue are specifically relevant to the creatine story, and the practical considerations for adults over 55 considering supplementation, including dose, form, kidney safety, and what a loading phase is and why it is unnecessary. Quick note before we begin, this is educational content based on published research, not medical advice. Talk to your physician before changing your regimen. Now, the study. Creatine is a compound synthesized naturally in the human body from 3 amino acids, arginine, glycine, and methionine, primarily through reactions occurring in the liver and kidneys. It is also obtained from dietary sources, with animal foods, particularly red meat and fish, being the highest dietary contributors. Vegetarians and vegans, who obtain little to no dietary creatine, typically have lower total body creatine stores than omnivores, a difference that makes these populations particularly responsive to supplementation in the cognitive studies reviewed by Forbes and colleagues. Creatine's primary physiological role is in the phosphocreatine energy system. In this system, creatine combines with phosphate to form phosphocreatine, which serves as a rapidly accessible phosphate donor for regenerating adenosine triphosphate ATP from adenosine diphosphate. ATP is the universal cellular currency of energy-requiring reactions. The phosphocreatine system is the fastest ATP regeneration pathway the cell has, faster than glycolysis, far faster than oxidative phosphorylation. In skeletal muscle, it powers the first several seconds of intense effort, the first rep of a set of deadlifts, the explosive push off the ground in a sprint. In cardiac muscle, it contributes to rapid demand matching during sudden increases in cardiac output. In brain tissue, where neurons have among the highest energy demands of any cell type and cannot afford even brief ATP deficits, the phosphocreatine system plays an analogous buffering role, sustaining neural firing during periods of high cognitive demand when oxidative metabolism cannot keep pace with the instantaneous energy need. The relevance to aging is direct on multiple levels. After 50, dietary creatine intake often declines if meat consumption decreases. A common pattern is older adults shift toward lighter protein sources or reduce overall food intake. Endogenous synthesis may not fully compensate for reduced dietary intake, particularly under conditions of elevated metabolic demand. Brain creatine levels have been observed to decline measurably with age in phosphorus magnetic resonance spectroscopy studies, neuroimaging technology that can quantify brain creatine in living subjects, and these declines have been correlated with changes in cognitive performance in aging populations. Creatine supplementation at 3 to 5 grams per day saturates the phosphocreatine system in both muscle and brain above the baseline levels achievable through diet and endogenous synthesis. In muscle, this saturation translates to the well-documented improvements in short-burst exercise performance, recovery between efforts, and training-mediated lean mass gains, familiar territory in sports science with decades of corroborating evidence. In the brain, the same energy buffering mechanism may provide meaningful protection against the ATP shortfalls that appear to underlie cognitive fatigue, slowed processing speed, and reduced working memory capacity in older adults operating under cognitive demand. A study published in Nutrients by Forbes and colleagues conducted a systematic review of the available randomized controlled trial evidence on creatine supplementation and brain function, drawing on both human trial data and preclinical mechanistic research. The review was specifically focused on cognitive outcomes, neurological health markers, and the biological mechanisms proposed to explain how creatine affects brain biology, going beyond the simple observation of cognitive effects to examine why those effects occur and under what conditions they are most pronounced. The review included studies across a range of populations: healthy younger adults, healthy older adults, adults with mild cognitive impairment, and individuals with specific neurological or psychiatric conditions including depression, traumatic brain injury, and sleep deprivation. For the purposes of the 55-plus audience, the findings in healthy older adults and in the sleep deprivation context are the most directly applicable, and the review analyzed these subpopulations separately from findings in younger or clinically impaired groups. A particularly important contribution of this review was its systematic examination of the sleep deprivation-creatine interaction. Older adults commonly experience disrupted sleep architecture, reduced slow-wave sleep, increased sleep fragmentation, more frequent awakenings, and overall shorter sleep duration, independent of diagnosable sleep disorders. Even modest chronic sleep disruption produces measurable cognitive deficits, particularly in working memory and processing speed. The review examined whether creatine supplementation could buffer these sleep deprivation-related cognitive costs. The creatine monohydrate dose studied in the majority of included human trials ranged from 3 to 5 grams per day as a maintenance dose. Some studies employed a loading protocol, typically 20 grams per day for 5 to 7 days, divided into 4 daily doses of 5 grams, before transitioning to maintenance. The review examined whether loading produced meaningfully superior cognitive or muscular outcomes compared to starting with maintenance dosing from the outset. This is a practically important question for older adults, for whom the higher doses of the loading phase are more likely to cause gastrointestinal discomfort. The review's approach to cognitive outcomes was systematically granular. It cataloged performance on specific cognitive task categories across trials, including tests of working memory, processing speed, declarative long-term memory, fluid intelligence and abstract reasoning, and executive function. This domain-by-domain approach allowed the researchers to identify which cognitive systems showed the most consistent and replicable response to creatine supplementation and which did not. The review found that creatine supplementation produced the most consistent and replicable cognitive improvements in tasks involving short-term memory and tasks measuring intelligence and reasoning, particularly under conditions of cognitive stress, fatigue, or high demand. Effect sizes in the cognitive domain were described as moderate but consistent across multiple randomized trials, which is a meaningful and relatively high standard for supplement research, where many compounds show initial positive results that fail to replicate in independent studies. The consistency across different research groups using different cognitive test batteries was one of the most encouraging features of the evidence base. In older adults specifically, the evidence pointed toward improvements in memory performance and reductions in mental fatigue during demanding cognitive tasks. The researchers noted that older adults appeared to show larger cognitive benefits from creatine supplementation than younger adults, a finding consistent with the neural energy depletion hypothesis. If baseline brain creatine levels are lower in older individuals due to reduced dietary intake and aging-related changes in creatine synthesis, supplementation has more metabolic room to produce an observable effect on neural energy buffering. The benefit is greatest where the deficit is largest. But that's not where the story ends. The sleep deprivation evidence was one of the more surprising and clinically relevant findings in the Forbes review. Multiple randomized studies found that creatine supplementation significantly attenuated the cognitive impairment typically seen after 1 or 2 nights of poor or disrupted sleep, including impairments in working memory, reaction time, and mood stability. This finding has direct and specific relevance to older adults, who frequently experience disrupted sleep architecture, reduced slow-wave sleep, more frequent awakenings, and earlier morning awakening even without a formal sleep disorder diagnosis. Creatine supplementation in this context is not a mechanism for replacing the restorative functions of sleep. It is a potential biochemical buffer against the cognitive performance costs of the sleep disruption that is disproportionately common after 55. On the muscular side, supporting evidence from exercise trials in older adults, including work by Gualino, Rawson, and colleagues, found that creatine supplementation combined with resistance training produced consistently greater improvements in lean mass and functional strength than resistance training alone, across studies conducted in adults in their 60s, 70s, and 80s. The lean mass benefit was particularly notable in older adults experiencing anabolic resistance, or achieving net muscle protein synthesis from training alone is harder. The review found that the muscular effects of creatine were most consistent and pronounced when combined with exercise. Supplementation alone without a training stimulus produced smaller and less consistent muscle mass effects. The limitations of this evidence deserve clear examination. Systematic reviews of cognitive supplementation face a particular methodological challenge. Cognitive outcome measures are heterogeneous across studies. Different research groups use different test batteries, some emphasizing working memory tasks, others reasoning tasks, others processing speed measures. Different populations are studied in different health contexts. Different doses, forms, and durations of creatine administration are used across trials. These differences make pooled effect size estimates noisy and direct cross-study comparisons difficult. The Forbes review acknowledged that the cognitive benefit evidence, while consistently directional toward improvement, was not uniformly large across all individual studies. Some showed clear improvements across multiple cognitive domains, others showed modest or null effects in specific domains. The summary conclusion of consistent improvements in short-term memory and reasoning represents the most replicated finding, not a claim of universal cognitive enhancement across all tasks and populations. The kidney safety question deserves direct and honest address, because it is the most common concern raised about creatine supplementation in the clinical setting. A long-standing concern in medicine has been that creatine supplementation elevates serum creatinine levels, which is biochemically true, because creatine is converted to creatinine as part of its normal metabolism. This rise in measured serum creatinine can be misinterpreted by an uninformed clinician as a sign of kidney dysfunction in a patient taking creatine, when in fact it reflects increased creatine turnover rather than impaired glomerular filtration. The standard biomarker for actual kidney filtration function, estimated glomerular filtration rate calculated using formulas that incorporate creatinine, may be artifactually lowered in creatine users, making the distinction between true kidney impairment and creatine-related creatinine elevation important to communicate to any physician monitoring kidney function. In adults with normal kidney function, the published evidence does not show that creatine supplementation at 3 to 5 grams per day causes kidney damage. This has been directly studied in clinical trials of up to 2 years. However, for adults with pre-existing chronic kidney disease, the interaction between supplemental creatine and kidney function monitoring requires physician oversight and individualized assessment. There's a catch that matters specifically if you're over 55. The loading phase, 20 grams per day divided across 4 doses for 5 to 7 days, is not necessary to achieve full phosphocreatine system saturation. Steady maintenance dosing at 3 to 5 grams per day achieves equivalent tissue saturation over approximately 3 to 4 weeks. For older adults, the loading doses carry a higher probability of gastrointestinal discomfort, including bloating, cramping, and diarrhea. The gradual approach is equally effective over a longer timeline and is substantially better tolerated. 3 takeaways from the creatine evidence for adults in the 55-plus window. Takeaway 1: if your physician determines this is appropriate, creatine monohydrate is the form with the most robust evidence. Not creatine ethyl ester, not buffered formulations marketed as more bioavailable, not proprietary blends at premium prices. Creatine monohydrate is used in the overwhelming majority of the trials reviewed by Forbes and colleagues. It is the most affordable form available, and it carries decades of safety data. The dose is 3 to 5 grams per day as a maintenance dose, no loading phase required. It dissolves in any beverage, is essentially tasteless, and is not a hormone, stimulant, or controlled substance. It is a naturally occurring amino acid derivative the body makes itself, provided in supplemental form to achieve tissue saturation above what diet and endogenous synthesis provide. Takeaway 2: creatine shows its strongest cognitive effects under conditions of mental demand, fatigue, and sleep disruption, precisely the conditions adults over 55 most commonly experience. The evidence does not support it as a general cognitive enhancer for well-rested adults. It acts as a neural energy buffer, filling energy gaps when cognitive demand outstrips ATP supply, particularly during fatigue, sustained effort, or the cognitive costs of poor sleep. For an older adult experiencing afternoon mental fatigue or difficulty concentrating after a disrupted night, the phosphocreatine buffer may provide measurable benefit. This complements addressing sleep quality directly, it does not substitute for it. Takeaway 3: The muscle benefit of creatine requires exercise. Creatine combined with resistance training consistently produces greater lean mass preservation and strength gains than either alone. For adults engaged in twice-weekly resistance training, adding 3 to 5 grams per day is a complementary strategy that enhances the training response. More available phosphocreatine means higher quality repetitions, greater training stimulus, and greater adaptation over months. The compound amplifies what training does, it does not substitute for it. Creatine monohydrate is one of the most studied supplements in existence, and the evidence for its relevance to adults over 55 extends into domains that are rarely discussed outside the context of sports science: cognitive function under demand and fatigue, neural energy buffering against the cognitive costs of disrupted sleep, and lean mass preservation when combined with resistance training. The Forbes systematic review identified consistent improvements in short-term memory and reasoning tasks, alongside the well-documented and widely replicated muscular benefits when creatine is combined with exercise. At 3 to 5 grams per day of creatine monohydrate, with confirmed normal kidney function, and an informed conversation with a physician, the evidence supports creatine as a considered and well-evidenced addition to the health toolkit for adults over 55, one of the few non-prescription supplements whose evidence base holds up to the kind of scrutiny this channel applies to the research it covers. The PDF guide on reading your biomarker panel, linked in the description, includes the kidney function and muscle mass markers most relevant to monitoring before and during any supplementation. Subscribe for the next video in this series. This is educational content, not medical advice. Always consult with your physician before changing your regimen. Studies are preliminary, individual responses vary.